Welcome back to A&P Live. We are here to digest complex disease processes, stripping away the surface-level symptoms to understand the exact mechanisms of failure inside the human body. Consider the case of Alejandro, a 51-year-old male with a history of HIV. He presents to the clinic with a 4-month history of thick, crumbling toenails, accompanied by severely macerated and fissured skin between his toes. Clinically, Alejandro is suffering from total dystrophic onychomycosis, paired with a concurrent case of tinea pedis. In a severely immunocompromised patient like Alejandro, this dual presentation represents an aggressive, localized enzymatic invasion of the deep tissue layers. To comprehend the severity of this microscopic tissue destruction, we must first analyze the structural baseline of the healthy human nail unit. Look at this healthy nail unit cross-section. The plate features tightly packed alpha-keratin. Abundant sulfur bonds lock these protein layers rigidly together, providing maximum protection. Moving down, we find the hyponychium, a tightly closed, waterproof anatomical seal connecting the nail to the toe. The hyponychial seal has a single critical function. It protects the highly vascular and vulnerable underlying nail bed from environmental pathogens. The healthy integumentary nail unit is a formidable physiological fortress. A fungal infection cannot simply wash over it. The pathogen requires a physical compromise of this protective armor to gain entry. The infectious process begins with microtrauma. Repeated friction from tight footwear physically cracks and tears open the hyponychial cellular seal. Through this breach enters the dermatype Trichophyton rubrum, an anthrophilic fungus that bypasses the broken barrier and immediately colonizes the nail bed. To survive here, Trichophyton rubrum secretes highly specialized extracellular hydrolytic enzymes, specifically subtilicin-like serine proteases. These proteases act like chemical scissors. They systematically target and cleave the peptide bonds of the alpha-keratin lattice, liquefying the once solid protein structure. The fungus then absorbs these freed amino acid fragments, utilizing them as its primary metabolic fuel to multiply and expand its hyphal network deeper into the tissue. Inside the dark, moist environment of a shoe, the fungi construct a complex three-dimensional biofilm network. This architectural shield provides extreme pharmacokinetic resistance, blocking both host immune cells and topically applied medications. The pathogen is highly adapted, but host genetics also dictate the severity of the invasion. Single nucleotide polymorphisms in the dectin-1 gene make certain patients highly susceptible to this specific organism. This genetic mutation sharply reduces the host's ability to detect fungal beta-glucans. Without that detection pathway, the host immune system is essentially blinded to the growing invasion. The combination of enzymatic protein degradation, a drug-resistant biofilm armor, and genetic immune blind spots creates a highly entrenched chronic localized infection. Once established, the localized immune system mounts a hyperproliferative response, attempting to rapidly shed the fungus. Clinically, this manifests as subungual hyperkeratosis, the dense buildup of debris directly beneath the nail. The characteristic yellow-white discoloration and onycholysis, or lifting of the nail, occur because the underlying keratin lattice has been enzymatically liquefied and detached from the nail bed. Meanwhile, in the interdigital spaces between the toes, the tinea pedis infection takes hold. Here, the dermatophyte secretes molecules known as mannins, which actively suppress local skin immunity. This localized immunosuppression allows the infection to degrade the skin unimpeded, leading directly to the severe maceration and painful fissuring we see between Alejandro's toes. Because Alejandro is HIV positive, his overall cellular immunity is compromised. This turns a localized integumentary failure into a critical systemic danger. The deep fissures between the toes act as direct portals of entry. Normal pyogenic skin flora, like Staphylococcus, can easily cross the compromised barrier. This creates a rapid complication cascade. A fissured skin barrier allows secondary bacterial entry, which can rapidly progress to cellulitis, travel up the lymphatic system as lymphangitis, or penetrate deep tissue to cause osteomyelitis. For high-risk populations, these fungal lesions function as open gateways for limb-threatening bacterial complications. Because the treatment protocols are intense, we must confirm the fungal diagnosis through laboratory testing to prevent the empirical overtreatment of patients. The most rapid office screening tool is a KOH wet mount of subungual debris. The potassium hydroxide dissolves the keratinocytes, allowing us to directly visualize the septate fungal hyphae under a microscope. For definitive analysis, a biopsy is subjected to a PAS, or periodic acid Schiff stain. This specifically highlights fungal carbohydrate complexes within the cell wall, leaving no doubt about the pathogen's presence. With a confirmed diagnosis, we transition to targeted pharmacology. Because the dense keratin plate and the 3D biofilms block the penetration of most topical drugs, eradicating the infection typically requires systemic oral therapy. The frontline defense is the oral allylamine antifungal terbinafine. Terbinafine utilizes a highly precise mechanism of action. This visual maps how the molecule actively blocks the squalene epoxidase enzyme located directly on the fungal cell membrane, completely halting the synthesis of ergosterol. Without this vital structural lipid, the membrane integrity fails. Toxic intracellular squalene accumulates rapidly within the pathogen, destroying the internal machinery until the fungal cell membrane ruptures and the organism dies. There are newer topical alternatives, like efinaconazole, which work through a different mechanism of enzyme inhibition. However, these drugs require highly specific, low surface tension formulations to successfully penetrate the dense alpha-keratin of the nail plate. Eradicating this stubborn pathogen requires matching molecular-level diagnostics with precisely targeted biochemical interventions capable of bypassing the biofilm barrier entirely. Mapping this infection through the macro lens of the human body reveals the interconnected tax on our organ systems, specifically the integumentary, lymphatic, nervous, and cardiovascular networks. The primary battleground is a structural failure of the integumentary system. The skin and nails lose their barrier function, but the burden continues inward. The lymphatic and immune systems endure a heavy secondary tax, burning resources to manage the chronic, localized inflammatory response and fend off secondary bacterial invaders. The nervous system plays a dangerous role in high-risk diabetic or elderly patients. Peripheral neuropathy can completely mask the pain of the initial hyponychial microtrauma, allowing the fungus to establish its biofilm undetected. Finally, the cardiovascular system becomes a limiting factor. Peripheral vascular disease drastically restricts blood flow to the distal digits, severely limiting the delivery of life-saving oral antifungals to the site of the infection. At its core, the pathophysiology relies on a physical breach. Microtrauma breaks the alpha-keratin barrier, dermatophytes secrete specialized keratinase enzymes, and form resistant, impenetrable biofilms, dismantling the tissue from the inside out. Clinical resolution demands meticulous diagnosis, followed by systemic pharmacology that precisely targets and destroys fungal ergosterol synthesis. Protecting vulnerable populations requires analyzing these infections through a rigorous, systemic, and molecular lens. The content in this video is for educational purposes only and is not intended as medical advice.